I will make a few comments regarding the use of alpha-1-antitrypsin to treat GvHD, specifically steroid-refractory GvHD. Obviously, alpha-1-antitrypsin has been used for many years for different indications. It is a protein our body produces anyhow, in the liver primarily, and it has been found to be very safe. And therefore, it was attractive to also try it in a situation where we have very limited resources, limited options, that is treatment of GvHD, particularly, as I said, steroid-refractory GvHD. How did we end up using alpha-1-antitrypsin? Animal models showed that it had a very profound effect on pro-inflammatory cytokines that everybody's aware of, that play a role in other conditions, arthritis, etc., also in GvHD. And those signals derived by pro-inflammatory cytokines play a significant role in amplifying the immune effect of GvHD. And as I said, since it is beautifully tolerated, we were little concerned about side effects and could focus on the efficacy in that setting of GvHD in patients not responding to steroids. In addition to an effect on these soluble factors, we could show that there is a profound effect on what we call regulatory Tcells, which are beneficial in the even in the non-transplanted body in establishing or maintaining tolerance, but also in the transplant setting, tolerance against the donor-derived cells. And furthermore, and that I think proved to be very important, there's always a concern when we suppress immunity to control the GvHD that we will also interfere with what we call the graft versus leukemia effect. So we might actually enhance the risk, increase the risk of relapse of the disease that we are trying to do. Well, we could show that alpha-1-antitrypsin actually increases the proportion of NK cells, the so-called natural killer cells. And by doing so, in the animal models, we could show that convincingly, it in fact enhanced the graft versus tumor, graft versus leukemia effect, and the progression of the disease was reduced, not enhanced. So very encouraging, and that is these observations confirmed by other groups. There's a recent paper by the group in Ann Arbor, University of Michigan, showing very similar results. We see a response rate in about 2/3 of the patients, and it is worth exploring the usefulness of this compound in other settings, particularly upfront, not allowing patients to become steroid refractory, and possibly even in a preventive fashion. That's where we stand right now, and I think those additional studies have been designed or have begun to accrue patients already.